Afternoon, guys. So I've been attending for about a year, so I'm closer to where you guys are than most of my colleagues in the ER. So I thought that it'd be a good perspective for me to tell you what I went through when I was applying for EM residency and how I even got into emergency medicine. So a little bit about me. I did undergrad at Texas A&M. Also, I did a Master of Public Health there. Graduated in 2004. And then I spent a little time in New York to up my science GPA at a post-bac program. And then I ended up here at UTMB. I completed my residency at University of Arizona South Campus program. And then I currently work at the Galveston campus in League City, and also I do locum tenens, which is like a temp agency for doctors, and I work in West Texas, Dallas area sometimes. So why emergency medicine? Why do we even think that this is a special field? What I liked about it is that I think that it's an integration of internal medicine and general surgery. In my third year, I was gung-ho about doing general surgery. I thought that that's what I was going to do, but I did fall in love with internal medicine, and emergency medicine, I think, gives you a good combination of both of those two. I really love doing procedures, and so emergency medicine is super procedure heavy. You have a great lifestyle. You get a lot of time off. You're not on call. You do shift work, so sometimes it can be hard to sleep when you're shifting back from days or nights to days. But I mean, you get used to it after a certain point. You can travel a lot. It's a super great lifestyle. One of my attendings that I worked with in Arizona, she goes on vacation every month with her kids. And you make a lot of money with it too. In the academic setting, you make more of like a $250 a year, and then in private practice, you can make $450, $600. Less than 1% of ER doctors leave the field each year, so you have a high retention rate of docs. And then you average about 39 hours a week, and then you see a lot of variety in your patients. So characteristics of somebody who's going to go into emergency medicine, they like treating life-threatening problems. So we don't really care too much about costochondritis or bronchitis per se. We want to know the thing that's going to kill you right now, today, and all the other stuff really doesn't matter to an emergency medicine doctor. You see a lot of patients on a daily basis, and it's you use your hands and hands-on physical diagnosis with this specialty. You see a wide array of acute illness, and basically your job is to stabilize the patient, and that's pretty much what we do. So in medical school, you learn how to do this long H&P. You ask a whole lot of questions, review systems, and in emergency medicine, it's just not that way. Sometimes you may not even speak to the patient that much. You have to stabilize them. Like if they have a tension pneumothorax, you got to do a needle decompression, and then you can talk to the patient later. Also, our presentations are just not how medical school style is. We just get to the pertinent positives, essentially. So when you assess a patient in the ER, you see them for maybe 10, 15 minutes. But in, what we've been taught in medical school, you spend a whole lot of time, maybe 30, 45 minutes. But with us, we don't have that much time to see a patient because you have more to see. In ER, you're going to use a lot of lab tests. We work with child and adolescent patients. You're going to use knowledge of circulatory, respiratory, digestive, and excretory systems. Also, you're using a lot of knowledge of anatomy and physiology, using knowledge also with many major diseases, and you see beneficial treatment results right away with your patients, and also outpatient operative procedures. So the ideal candidate going into emergency medicine, when I was in medical school, 220s was about where we were shooting for step one. What are they telling you guys now?
It's like 230 now.
230. Okay. And then also for ER, research is really not that big of a deal, not like your surgical subspecialties like plastics or ortho. We really care more about the step scores and then really doing well on your clerkship, EM clerkships and away rotations. And then to help guide you with everything, you really should select a mentor early on when you decide you want to go into emergency medicine to help. So what residencies are looking for and the typical ideal candidate, they want to see somebody with great work ethic. You're going to be working long hours, doing a lot of charting notes. They want to see somebody that has endurance to deal with this type of specialty, somebody who has integrity, decisiveness, procedural competence, and an overall team player. You really, in order to be a great EM physician, you really have to know your nurses well, EMS personnel. You have to really create good relationships with all of them in order for it to work out, in order to have a great shift. Just a little spiel about why Texas is great to work for emergency medicine. The malpractice laws are really good here. There's a cap on how much that a patient can sue you for, and in all actuality, it's really difficult for a patient to sue EM doctors here. You have to really prove intentional negligence, that you absolutely just wanted to harm the patient, which nobody comes to work wanting to do that. So our malpractice laws are just more stricter here than anywhere you practice. Also, you make more money in Texas, so a lot of people come here because there's no state tax, so you make more money and you're more protected with malpractice laws, so why go anywhere else to practice, I say. VSAS, this is the website that you'll go to when you're starting off for your away rotations. Not all of the programs are listed on this website, but a majority of them are, and it's easy to help you figure out which programs you want to do your away rotations at. You can choose the location based off of this website. And one thing that I found, I did my away rotations at Texas A&M and Baylor. I kind of, like I said before, I initially thought I was going to do general surgery, and then I kind of scrambled into emergency medicine at the last minute. So I did A&M, and I didn't realize that they had a test, but you want to make sure that you do well on these tests. Or if you don't want to go to an away rotation that you really don't want to study for a test, you rather show the attendings that you have great work ethic and just basically focus more on the clinical aspect instead of working on a test, because if you do bad on that, then it can really affect your SLOR. So really know what you're getting into before you apply to these places. And also, before you even do VSAS, we welcome you guys to come to our ER and hang out with us and figure out if emergency medicine is even what you want to do. And like I said before, the standardized letter of recommendation is everything. This is what really helps these residency programs set you aside from all other applicants. You have to really get a good SLOR. Organizations to join, aside from this one, EMRA is really, really good. They have a lot of books and resources that even your attendings today still use. ACEP, American College of Emergency Physicians, is really great. SAEM and the American Academy of Emergency Medicine. The reason why you want to join as many emergency medicine programs or organizations as you can is because you want to demonstrate that your interest in the field. So for somebody who's applying and they only are assigned or signed up for one organization, it's not really showing or demonstrating that they're even interested in it. So the more organizations you join, the more interest it shows. This is just one of the books from EMRA that is golden. Like all of your attendings today still use this, the antibiotic guide. It's just one of many of the resources that you can get from them. So when you actually go on these away rotations, how do you rock it? You want to be aggressive, eager, and show a lot of enthusiasm. So if there's a lot of patients on the board, they don't want to just see you sitting down at the desk. They want to see you getting up to see patients. And this is also something where you want to come early and stay late. They want to see that you have some endurance. One good thing about your away rotations is that you can actually interview while you're there, so you don't have to fly back out to these places. You also need to build some knowledge base while you're there. One resource that I found was really good is HippoEM, which is an online review course. And I think for medical students, the price of it is like $200, but it basically provides a good fundamental knowledge base for emergency medicine and what types of patients we see, the presentations. So I think it's really good. You could possibly also use something like case files and also something called EM Med Student Clerkship Primer, just to help you develop some type of knowledge base while you're doing your away rotations. Another important thing is that you don't want to pick up too many patients. So for a med student, you may have maybe 2-3 patients. You want to know those patients really good. And then you also want to know the differential diagnoses for such things as chest pain, belly pain, shortness of breath, what an emergency medicine physician is looking for. So for chest pain, like I said before, we don't really care about costochondritis, but we do care about heart attack, pneumothorax, esophageal rupture, aortic dissection, stuff like that. One good thing to help set you apart from the rest is that you want to stay on top of what is pending for your patients. You want to be the first to know before they're attending, before the resident. So you want to constantly be checking lab results and imaging. And also be nice to every single person at these away rotations, the secretary, the coordinator, everyone, because they all talk to each other. And if you're mean to somebody, it can be reflective on your floor, and then that just messes everything up. So this is a little YouTube video that I found from the Emmer website, and you guys can look at it at your leisure, but it actually gives a lot of tips on how to rock the EM rotation as well. You have to be able to multitask, be resilient, bring your A game, that goes without saying, and really be all in. So what that means is that you want to do whatever the intern is doing. So if they're going to journal clubs, their conferences or didactics, and procedural skill labs, you want to do all that what the intern is doing, because you want to show that you can hang with the best of them and be basically an intern. Another thing while you're at these away rotations, that you want to get a lot of face time with the attendings, particularly the program director, so that when you interview with them, they know how you work in the emergency room and how great you are. Another thing is that you don't want to throw your residents under the bus. So I know that you want to stand out and do well and show that you know all this stuff, but you actually want to work more with them. So ask the resident what you can do to help them with a patient, but don't try to outshine them, because that can look bad. So every emergency medicine away rotation grades you differently. Some of them are just pass-fail, some of them you honors, high pass, pass. But the gist of it is you want to do well on your away rotation. I found that there were some 3 articles, behavioral-based articles, that basically give the ideal characteristics of outstanding emergency medicine medical student. One of those articles is the AAEM Resident Rules of the Road, and basically it tells you how to be a rock star, how to ask for feedback from your faculty, and how to prep for these away rotations. Another article that I found was helpful is from Denver Health, where it shows you how to present an emergency medicine patient. 'Cause like I said, it's super different from what you learned in medical school. So the 3-minute medical student presentation I found was really helpful. And then this other article by Gus Garmel, the outstanding medical student, just gives a lot of characteristics about what you need to possess in order to do well on these rotations. And ultimately, like I said before, you want to function at the level of an intern and really have a sense of ownership of the patient. So you want to be the first person to know what labs are back, what imaging is back on your patients before the attending or the residents. Questions that you can ask about clerkship expectations. You want to know what clinical responsibilities you're going to have, which facilities you're going to work, because some places have two or three different facilities. You want to know who's going to evaluate you guys. Like I said before, you want to know if there's going to be a written or oral exam at these away rotations. And you definitely want to make sure you can get an interview before you leave. Housing is a super big deal too, because this stuff can be really expensive. So you want to see what housing opportunities they have at these places. And then, of course, you want to know the conference didactic lecture schedule. FREIDA, this is the website that you're going to use to help you find your actual residency spots. What's important when you start looking for a residency program is you want to know based off of location. Honestly, in retrospect, after going through residency, you're going to get the same training anywhere you go. So you want to go where you're going to be the happiest at. If you have a good support system in Texas, then you will want to stay here. But location is pretty much the main deciding factor as far as where you should apply for these programs. You also want to know what type of shifts these residency programs do. Where I trained at, we did 9-hour shifts, and we stopped picking up patients the last hour and a half, so it helped you wrap up things towards the end. But I know like UT Southwestern, they do 12-hour shifts, and what you have to be aware of is that the shift is not just over after at 9 or 12 hours. You have to do a lot of charting as a resident. So average charting time could be like 2 to 3 hours after. So you just have to keep that in mind when you're applying to these places. Also, you want to know what type of experience you're going to have. Some residency programs, they don't have orthopedic surgery rotations where you learn how to do fracture reductions and all that stuff. Some have sports medicine instead, so you want to review that, because if going to a place where you have an actual rotation ortho may be important to you. Also, if you want to do a fellowship, you want to go to the places that have the fellowships that you're interested in. And then also, you want to be aware of which facilities you're going to train at. Is it a level 1, 2, 3, or 4 trauma designation center? If you love trauma, then you want to go to a place that's level 1, because you're going to see all the major traumas. If you don't really care so much about it, then maybe training in a place that's a level 3 or 4 is more your speed. Also, you got to keep in mind the patient volume. The more patients that an institution sees, the more opportunity for you to learn. So you want to go somewhere that has a lot of patient volume, because that's more experience and more opportunity for you to learn. Factors in picking a program. So you want to know the quality of the training program. Some places are brand new. You may not want to apply to a place that just started up because it's going to have a lot of kinks in the program. You want to go to a place that has diversity of training experience. Some residents really want more conference and didactic teaching, so every week you'll have conference. We had conference for 5 hours every Wednesday, and this is really pertinent to your learning. So if this is really important to you, then you need to review the residency program to see how much time do they dedicate to conference. And then, like I said before, high patient volume is always good. And you also want to know about moonlighting experience and what stipulations you need to know about in order to do that. Because as a resident, you don't really make that much money, but if you can supplement your income with moonlighting, that may be helpful. And just to reiterate, you want to know the quality of the training program, house officer satisfaction, your general impression at the interview, diversity of training experience, the location, resident staff quality makeup, faculty staff quality, and then the personal fit with the program. So just to go over a little bit, what does the level 1 trauma designation mean, and so on and so forth. So level 1, really the major difference is that you're going to have 24-hour coverage by all of the specialties, and then they also emphasize that a level 1 trauma designation means that they have ongoing research. They also have referral resources for communities in nearby regions. They provide leadership and prevention of public education to surrounding communities, and they provide continuing education of the trauma team members. But overall, with all that being said, they just have all of the surgical subspecialties available 24/7, and they provide research. That's the main thing. Level 2 is going to work in collaboration with level 1. It provides comprehensive trauma care and supplements clinical expertise of level 1 institution. You also have some of the surgical subspecialties on 24 hours. And with level 2, they're not required to have ongoing program of research. And the minimum volume required may depend on local conditions. For level 3, they don't have to have a full array of specialists. They have resources for emergency resuscitation, surgery, and intensive care of most trauma patients, and they have a transfer agreement with level 1 or level 2 centers. And then level 4 just provides the initial basic evaluation, stabilization, diagnostic capabilities. They may provide some surgical and critical care services. So ERAS, this is the program that you're going to use to actually apply to the residency programs. When I was a med student, we were told 20 to 25 programs was good. What are they telling you now?
It's like twice the amount now.
Oh, God.
Yeah.
Okay. All right. So because it's getting more competitive, everybody's catching on that this is a good field. So when you're applying, you want to make sure you know if this is going to be a 3 or 4 year program. Most EM residencies are 3 years, and just a handful of 4. Obviously, you want to be thorough, neat on this application, be super early, and be organized. This is another little YouTube video from EMRA that I thought was helpful, and you could look at it later. So details of ERAS, so you want to keep in mind activities that are pertinent to emergency medicine to highlight. So work experience, like if you were an EMT before or a nurse in the emergency department or something like that, something that's pertinent to it, that's what you want to put on your application. You want to include brief details about your activities, your leadership roles, research, honors and awards, teaching experience, volunteer activities. And I would really only put volunteer activities that are pertinent to emergency medicine as well. And because for me, I did like a lot of volunteer activities, but you can't fit all of that on there, and I don't think all of it's important. I would only do what is pertinent to EM. And then, like I said before, you want to join every organization that you can to show that you have interest in this. So when you get to the time when you get your interviews, one thing that I thought was super helpful is that if you haven't heard from a residency program that you really want to go to, call them, because a lot of people are canceling their interviews, and you may can get a spot, and that might be the place that you end up going to. Always send a thank you note. This could be handwritten or typed out, but always send that. That looks very well. And I remember when I was applying, the Student Doctor Network had a list of questions that they typically ask at these residency interviews. So I thought that that was super helpful. And always go to the night before dinner or gathering that they have before your interview, because it gives you a chance to really see if you can fit in with the residents. It gives them a second look at you, because they'll remember that you did the night before and then you came to the interview. I just think that it's super helpful. And then you want to wear a traditional suit and attend their conferences if you can. And this is another YouTube video that you can watch later from Emma's website that I thought was helpful. So basics to the interview: you want to show some enthusiasm. You want to definitely know how to pronounce the interviewer's name and know your questions. You're going to be asked 1,000 times when you go to your interview, do you have any questions? Everybody's going to ask you this, and you must have some questions to ask, because if you don't, it looks like you're not interested. So example questions that you can ask: how do your graduates do on the boards? Are there non-clinical responsibilities? What patient population will I encounter? What type of resident evaluations are used? Is there a mentor-mentee system? And do you anticipate any changes in the program, or just a few? And then questions that you can ask the residents are: would you choose this program again? What has changed since you came to the program? How much didactic time is in your program? Call rooms, meal plans, parking. I can tell you as a resident, meal plans are everything, because you don't have time to go home and cook. So you want to know what their meal plan is. Like I said before, moonlighting rules is important, and you want to know if the residents socialize outside of work. Example questions that they may ask you: list 3 accomplishments that you're proud of. Tell me about yourself. I think that that was probably the most popular question when I was interviewing. Strengths and weaknesses. What do you do in your spare time, and how do you normally handle conflict, and why did you apply to this program? So for any interview that you go on, you want to do your research. You want to look at their website extensively, because they may ask you questions about that. So you want to make sure that you do your homework before you go to these interviews. And then how to rank your programs. You want to go with your gut, do your homework, find a program that actually matches your interests. Factor in your support system. That's going to be important. And then, like I said, if trauma is really your thing, then you want to go to a trauma-heavy place, pediatric experience and ICU experience. And then you can also do a second look. So if you really kind of are iffy about the program, you can go back and just set it up with the coordinator to go back and do a second look at the site. And then some of the fellowships that you can do in emergency medicine include toxicology, sports medicine, ultrasound, which is a really popular one, critical care, which is 2 years. Most of these are 1 year. Toxicology is 2, EMS, pediatrics, and wilderness medicine. Once you finally get through all this and you get to residency, the way that you stay on top of your knowledge base is to read about 1 patient per day. I thought that that was super helpful for me. So if you had a patient who had a heart attack, then you can just go home and read everything you can about heart attacks. Tetanales is the Bible of emergency medicine. It's a huge, thick, red book, and you'll have to read that. Peer 8 is a question bank, which is super helpful for your written boards. Rosh Review is another question bank that I thought was super helpful for fundamental knowledge. And then HippoEM is really, really good. Whenever you finish with all of this, job opportunities, you can create where you work at. So once again, with the example of trauma, if you decide that you really don't like to do trauma. You can go to a facility that doesn't really have trauma, or like here at our ER, we have a trauma surgery service, so they see all of the major traumas and we just see all the minor ones. If high acuity is your thing, you can pick a place like that as well. You can just do urgent cares. Some physicians, they don't want to do high acuity patients, so they just do urgent cares. And then freestanding ERs is a new thing. A lot of physicians are migrating towards that. They do 24-hour shifts, and a patient volume on a shift may be like 10 or 12 patients, but you get all of your hours out of the way. So it's another thing. It's an up-and-coming thing a lot of people are doing. You could, of course, do academics, and then locums is really good if you don't really know what you want to do. You can do these term assignments, so like maybe 3-6 months you can go work in Alaska if you wanted to, or New York. But what I do like about locums is that you have such a variety and you get to travel a lot, and the companies will pay for your plane ticket, for your rental car, and your hotel. So all of that is no expense to you. And then you also get paid for charting at the end of your shift. So if you end up having to chart 2-3 hours after your shift, you get paid for that. And with other jobs, you don't. You just get paid salary or per hour. But with locums, you can get extra money with that, so it's good with that. What I don't like about locums is that you don't really get a chance to get a good relationship with your team members. So like the nurses, you don't know who you really can trust. You have to learn different EMR systems, so that can be a little bit of a challenge. But as far as variety goes, it's really good. Some of the challenges of emergency medicine that you hear about, there's a burnout a lot with it. And then it can be a high stress level with this type of job. But I mean, you could curtail it and change your work environment. So like I said, a lot of EM docs are doing freestanding ERs where they're seeing less acuity patients and less volume. So you could help change that. One other thing that's really a challenge is difficulty with consultants. So you spend a lot of your time on your shift trying to sell the patient to get admitted to somebody, or for a specialist to come down and see the patient. And sometimes this can be a real challenge, especially at an academic institution, because there's no incentive for the residents to see the patient. They still are going to get paid the same exact money. But in the private sector, the more patients they see, the more money they make. And so you really don't have as much difficulty with consultants seeing them in private practice. It's a people-driven field. So you're going to have difficult patients, you're going to have the drunk patients, the psych patients, and sometimes that can be a challenge. It can be long hours sometimes, and then you lack continuity of patient care. But for me, I'm fine with that. I'm kind of like a treat and street type of gal, so I'm fine with lack of continuity with my patients. And you also lose a little bit of respect with emergency medicine. You can from your specialist colleagues. So somebody who does cardiothoracic surgery, they train for 7 years and you've trained for 3 with emergency medicine, sometimes they don't respect you as much. So to sum it up, procedural skills, things that you will get really good at is codes and CPR. So that's really where we come to life. That's really our thing. Intubations you get really good at. Central lines, laceration repairs, lumbar punctures, pericardiocentesis, fracture reductions are just to name a few. But overall, emergency medicine, mainly what we do is codes. That's our thing. So this is my email address if you guys have any questions. Whenever you get closer to this stuff and you forgot all about this, you can email me if you have any questions. And do y'all have any questions now?
So you said that you do locums?
Uh-huh.
So how does it work where you do that and then work at UTMB as well? Like, how do they allow for like schedule in terms of scheduling?
Well, it's just you do it based off of your days off here at UTMB. That's how I do it. So we get our schedule maybe 2 months in advance, and so that's how I can sneak in a couple of shifts. I only do like 3-4 days of locums. I don't do the long-term assignments. Yeah.
I guess for away rotations, when do you recommend starting to try to look into that, and how would you go about trying to go to specific away rotations?
So you're going to do that at the beginning of your 4th year. So I would start like maybe at the middle of your 3rd year just doing some research as far as which places you want to go to. Yeah. Mm-hmm.
Yeah, you did mention that research is not really big as
Yeah.
far as the end, but if somebody had research versus somebody who did not do research, do you think they'll have a little bit more of an edge?
They may, but that's just not a big emergency medicine thing. They look more at your clerkship. That's like the main thing they want to make sure that you do successful at is the clerkship. So if you did kind of mediocre on your clerkship and then you had the research, maybe that would help, but the main thing is your clerkship and your step scores. So, all right. And if y'all have any other questions, you can email me at any time. I hope that this was helpful for you. It's kind of a lot of you are 2nd year, so you're not at this point yet, but you know, I thought that, you know, going through all of this, you just learn a lot of tricks of the trade going through it, and it flies by really fast. So 3rd year will be here before you know it. All right.
Can we get a round of applause for Dr. Robertson? Thank you. So a couple things that I want to mention. I went and talked to, or at least I emailed one of the interns that graduated from here, and he forwarded me a bunch of materials because I asked him about more resources just for our 3rd years and 4th years, and so I'm going to send that out. And so he gave me like a page worth of stuff because he's also working with like this task force for emergency medicine, and I forgot what it's called, like CDEM or something, but he's part of that, and so I'm going to send that out. I think that's going to be really helpful. You know, if you have any questions, you can contact Dr. Robertson or one of our faculty members. There's also part of EMRA. They have this mentoring thing where if you sign up, as long as I think you have to be an EMRA member, but you join and they have you put in your information and they match you up with a resident from anywhere in the United States, and they kind of mentor you and you can ask them any kind of questions. And I remember a couple of Baylor residents were talking about that, and so they think it's a really great program, and so just wanted to throw that out there. And that's it. Thank you guys.